Good afternoon and thank you for joining us today. We will be getting the session started very shortly. While everyone logs on, please make use of the chat function and let us know where you're from and what your site is. Good afternoon again and welcome. My name is Ashley Arkell. I'm the National Education Coordinator here at the Stroke Foundation. This is the first webinar in our two-part Somatosensory series. We are delighted to have the expertise of the Neuro Rehabilitation and Research Recovery team from La Trobe University here to present as part of Stroke Foundation's national webinar series. I'd like to introduce our presenters today, Professor Leanne Carey and Yvonne McEwan. Professor Carey is the lead developer of the SENS approach to help stroke survivors regain a sense of touch. She is recognised as a world leader in evidence-based rehabilitation and translation of neuroscience to stroke rehabilitation. She is Professor of Occupational Therapy, School of Allied Health, La Trobe University, and head of the Neuro Rehabilitation and Recovery Research Group in Stroke at the Florey Institute of Neuroscience and Mental Health in Australia. Yvonne McEwan is an occupational therapist working clinically and in research. She is the assessor lead for the SENS program of research, and her studies focus on the development and trialling of standardised quantitative somatosensory assessments used in clinical settings for adult stroke survivors. On behalf of the Stroke Foundation, I'd like to thank Professor Carey and Yvonne for sharing their knowledge and expertise with us. We look forward to learning from you today. We also have with us Leah Pett, who is Stroke Foundation's Queensland Hospital Coordinator. She will be facilitating our discussion today. Before we begin, I'll briefly run through some housekeeping. A webinar is an interactive webinar. We encourage you to use the Q&A function at the bottom of your screen to submit your questions as you think of them. We will answer questions in the second half of the session. If you see a question that someone else has asked that you also would like answered, you can click the thumbs up button under the question to vote for it. All registrants will receive an email with the resources mentioned and a link to the recording. At the end of the session, there will be a short survey where you can also register to receive a CPD certificate. Before we begin, we would like to acknowledge the traditional custodians of the lands on which we all meet today and pay respects to elders past, present, and emerging. I would like to acknowledge that I'm joining you today from the lands of the Darkinjung and Gurungai people. I'll now hand over to Leanne and Yvonne to begin the presentation.
Thank you, Ash. And on behalf of Yvonne and myself, I'd like to thank each of you for your time and interest in joining the session today to look at this somewhat hidden problem of sensory loss after stroke, and particularly to be prepared to ask the question, where do I start with understanding and assessing the somatosensory impairment following stroke? There's four main areas that Yvonne and I would like to cover today with you. First, I'd like you to consider why sensation in the context of stroke rehabilitation and what we might be able to achieve from addressing this problem. Next, we'll introduce you to three standardised assessments that might help you to understand and assess the presence of sensory loss. It's important also that we assess the sensation in the context of functional activities. And so we'll provide you some ideas and structure around how you may be able to look at assessing the sensation in the context of everyday tasks and give you some tips of how you might fine-tune your observations to really pick up the sensory problems. And finally, we'll finish with looking at sharing some resources to help you apply some of these ideas in the context of your everyday clinical practice settings. So why sensation? always think it's important to start with the lived experience. And if any of you have heard me talk before, you may have actually seen this video. This is a video of a stroke survivor who was a young mother who experienced sensory loss after giving birth to her child. And I think this really tells, sort of shares the experience of the sensory loss, and it's something that I take with me to help connect with the many layers of the impact of sensation, and also why, in fact, I've been involved in this area of practice for the last 30 years. So let's have a look at this video.
Making a bed, for instance, tucking the sheets in, that bothers me every day because I can't feel. Okay. And as soon as my hand comes out, the sheets will come out. Like cooking, because I burn my hand cooking a lot.
I see.
Yeah, and that makes me depressed. Or my daughter, she's teething, and she will bite my hand and I can't feel it.
Okay.
And that will make me depressed. You just don't feel confident in anything that you do, and you get depressed. Like changing my daughter's nappies, because I cannot feel them, and I cannot feel her in my hands. I can hurt her, and I can bruise her with my hand, and I've done that in the past week. And it takes me a while to get those coins out of my purse, because I have to hold my purse with my good hand so I can feel it.
Okay.
I need to use this hand to get the coins out. People behind me will get frustrated because I'm taking so long.
I see.
And on the outside, I look all right.
Did you feel that every day?
Every day when you go shopping, yes. Doing dishes can take me up to an hour, even sometimes 2 hours. Because my hand, I can't feel things in my hand.
I see.
And I can break glasses in my hand because I can't feel them. I don't know the force that I'm holding them.
And that makes it take longer.
Yeah, well, I break the glass, so therefore I've cut my hand and I have to go and fix that, and then I forget of what I was doing.
I see, I see, yeah.
It just happens. And that can happen 2 or 3 times a week.
I think that tells you clearly the impact of the sensory loss and really highlights how important it is to listen to the voice of the people that we're working with. So what do stroke survivors who experience sensory loss say in relation to that loss of sensation? Megan Turville in our group has conducted a phenomenological study to help capture some of those experiences and what they're saying. So as you see here, people report, I don't feel nothing at all, no sensation at all. Or as Maria says, I couldn't really do daily stuff. I couldn't hold anything. Things were just dropping. Yeah, so I had nothing. There was nothing there. And Veronica, it's very difficult for people to understand the experience that you're having when you can move your hand, but you can't feel. And no one around you will accept that it's real. You're kind of fighting on both fronts. It's also important, I just wanted to highlight that there's some great examples and further sharing of experiences on the Stroke Foundation Enable Me site. And I refer you to that to further get an insight of the lived experience for many people who experience sensory loss after a stroke. So we've looked at the personal side. So the next thing is really to think about, well, why we need to look at this in the context of stroke rehabilitation. Importantly, we need to realise that in fact, 1 in 2 stroke survivors experience sensory impairment. And as they often say, it's like the hand is blind. This sensory loss negatively impacts not only one's ability to interact with the world around them, but also then to use their hand for pinch grip, hand function, and goal-directed arm use. And as you can imagine, that has ongoing impact in that person's ability to return to previous life activities and work. The evidence has shown that it's associated with poorer functional outcome, yet despite all this, it's still a neglected area of stroke rehabilitation. The good news is that the potential exists to reorganise brain networks and actually to improve some of this lost function. And so I suggest that our aim should be to really regain a sense of touch so that people can then use it in daily activities. As a clinician, I like to organise my thinking around sensation on 3 levels. And hopefully this might be something you can use as well. Sensation for perception, sensation for action, and the impact of sensation on participation in daily activities and life roles. So if we look to sensation for perception first, we really need our somatosensory function to detect, discriminate, and recognise sensory features of both our body sensations and objects. Importantly, if we think about this, we use the exquisite receptors and ability of our senses to pick up information, couple this with a sensing brain to extract features of objects that we interact with on a daily basis. So, for example, to feel the surface of a texture or the shape of an object. The important thing at this level is that it involves attention, often a sensory goal, and it's linked often with optimal exploratory procedures. So if, for example, and I'd like you to try this now, if I ask you to feel the texture of the surface of the chair that you're sitting on, just stop and do that now. Versus feel how hard the chair is. Hopefully you would have noticed that the way you explore that information, that sensory goal, will vary with the different features of exploring for textures or for pressure. And that's an important thing for us to recognise because it can be a window into our observations of what your client's doing as well. At the next level, we think about sensation for action. And this is where it's the interaction with motor function. And there's certain types of motor function or movements that are particularly challenged when a person has sensory loss. For example, with pinch grip and or combining reach and grasp type movements. Here we're looking at goal-directed action and really realising that sensation is part of the feedback loop and a critical part so that we can adapt movements to achieve the goal of the use of our hands that's involved with. If we look at the impact at the level of participation in daily activities and life roles, these might be things like eating, cooking, life role as a mother. The most important thing here for us to remember, it involves choice and motivation. So think about where it impacts for your particular client and how that is experienced in the daily activities they need to engage in. But despite the importance of this, both from a significance and personal level and the high prevalence is, unfortunately, our national survey has indicated that 70% of OTs and physios are not currently using standard or published assessment. So there's a potential here that we are missing this problem, and it's certainly something that repeatedly I hear from the clients that I work with who have sensory loss, that it may not have been picked up. So this is an area for us to think about change. And the good thing is if we're able to pick it up, then there are some avenues for treatment and actually helping people regain a sense of touch. And there's some practice guidelines related about that with evidence-based approaches, which we'll actually address in the next webinar as well. So I'd like to pause here and hand over to Yvonne, who's going to share with you some information on some standardised assessments of somatosensation. Yvonne?
Thanks, Leanne. So there are various quantitative measures which assesses for function. And Leanne, you can move on to the next PowerPoint. And these has been developed to specifically assess for one's discriminative sensory capacity. So here we have 3 quantitative norm-referenced assessments that measures discriminative sensation, and these include the tactile discrimination test, the wrist position sense test, and also the functional tactile object recognition test. And these 3 tests will be discussed today. Now, these quantitative tools are standardized and reliable, and therefore are able to be used in clinical practice settings with stroke survivors. So let us talk a little bit more about the tactile discrimination test first by showing you a brief demonstration video of Leanne performing the actual test with a stroke survivor.
The tactile discrimination test assesses texture discrimination ability using finely graded plastic surfaces. The therapist introduces the test to the client using standard test instructions.
Damien, the purpose of this test is to see how well you can feel different textures. The textures are in sets of 3, as you can see here. In each set, 2 surfaces are exactly the same and only 1 is different, okay? So the texture that's different may be rougher, as you can see here, or it may be finer, as you can see in this set. Also, the surface that's different could be in any position. So it could be in the middle, as we had here, onto one side or on the other side. Now, using your preferred finger, I'm going to ask you to feel from one texture surface to the next. You may move freely between the surfaces as you wish. I would then like you to tell me which surface is different, so the odd one out, by either putting your finger back on it or telling me its position, so 1, 2, 3. Now, there'll always be one surface that's different, and the surfaces range from quite large differences, as you saw before, to small differences. And some of the differences can be quite small, as you can see here, and difficult to distinguish. So if you don't know which surface is different, it's okay to guess. Just do your best, and often your guesses will be good.
After you've explained the test to the client and you're satisfied that they understand, it's time to proceed with the assessment.
So I'm holding your hand there, and this is the first one to feel. So first, second, and third.
I reckon the middle one is
The
different.
other one could be different.
Record the client's response in the space provided for each trial.
Great. So you can see from the video that the tactile discrimination test really measures the ability of the stroke survivor's ability to discriminate different differences in finely graded surfaces. It uses a 3 alternative forced choice design, and it has normally standards that has been defined and matched pair samples. It also has a high test-retest reliability based on a sample of stroke survivors. The original test trials is 25 trials, but there is an option of completing this test with shorter trials, which is 12 trials. And it's been shown that even with the shorter trials compared to the original 25, it has quite a high sensitivity and specificity. Now, the next one is the wrist position sense test. And again, we're going to be showing you a video demonstration.
The wrist position sense test is employed to quantify a person's judgment of their wrist position following an imposed movement of the wrist, and thus sample their proprioceptive discrimination ability.
The purpose of this test is to see how well you can feel the angle of your wrist and where your hand is positioned in space. I'll move your hand to different positions using the lever like this. You'll be required to use this pointer
to indicate the position of your hand underneath.
Yep.
Now this pointer lines up with the position from the middle of your wrist
Yeah.
through to your index finger, so you don't need to worry about where your thumb is, okay? Now I'm going to take your hand to 20 different positions in a random order, and those positions might be indicated by either the large markers or by the smaller markers in between, okay? When I take your hand to the position, it's best to indicate your judgment as soon as possible,
Yep.
okay, afterwards. Do you understand?
Yep.
Great.
Start at the 90-degree position, then move directly from one position to the next.
This is the first position now.
110.
110.
Move the client's hand to 20 test positions in random sequence, as indicated on the testing sheet for that hand. Make sure you use the test form that matches the hand being tested.
So the wrist position sense test measures the ability for the client to indicate wrist position following an imposed movement of the wrist. It requires the client to match 20 predetermined imposed wrist positions using the protractor scale as you've seen in the video demonstration there. Again, it has normative standards for adults, and it has a high test-retest reliability as well. So the 20 predetermined imposed wrist positions is really for the original 20 version. However, again, there is an option for therapists to do a shorter, briefer test, which is 10 positions, again, yielding a high sensitivity and specificity as well. And finally, we'll have a look at the functional tactile object recognition test.
The functional tactile object recognition test is designed to quantify one's ability to recognise common objects through the sense of touch.
This is a test of your ability to recognise everyday objects by touch. So I've got pictures of these everyday objects on the table, and they're ordered approximately from large going down to quite small objects. Some objects are more alike than others, and each object has a number to identify it. I've also placed 5 actual objects above the poster to help you work out the size of the objects shown in the photographs. So for this one here, that's the metal bowl. The spoon, as you can see, is a dessert spoon, a full jar of mayonnaise. This is your business card and the key, okay? Now, within each object set, size is constant. So, for example, the key that you see here is the house key, and this, therefore, is a smaller key linked with it. So there's a real difference inside within an object set. So first of all, can you see all the objects clearly?
Yes.
And any questions about what any of them are?
Nope.
Okay, great. So what I'm going to do on each trial, I'll give you one actual object to feel. I'm going to put it behind the curtain.
Yeah.
Okay. And as soon as you recognise which object it is, just put the object down and tell me the matching object by either pointing to it or by using the object number. It's best if you don't feel the object anymore just at that point in time. Now, not all objects will be used, and you may be presented with the same object on more than one occasion. So it's important to select the object that most closely matches what you felt, okay? Now, sometimes you can hear a sound associated with objects that you're feeling, and that can be a bit confusing. So we ask people if you're happy enough to wear headphones, or we can use earplugs if you prefer.
No.
Great. Now, I will be timing your responses, but remember, accuracy is actually more important than speed. And we'll have a practice trial first to make sure you feel comfortable.
The client's hand to be tested is placed through the curtain and their arm resting on the table.
Okay, I'm going to give you the next object to feel in your hand now.
Record the time taken for their response. If the client requests a second exposure, record the additional time.
So you've got hold of it there.
Yeah. The bowl.
The bowl maybe.
Yeah.
Record the exploratory procedures by circling or ticking on the scoring sheet. Multiple exploratory procedures may be used during exploration of each test item.
So this test measures, as we've already seen, everyday objects across 7 somatosensory attributes. The client is required to feel the object behind the screen and then choose a matching object from the poster, which is presented to them in front of them. Again, it's been seen to have normative data with the adults with excellent internal consistency, has a discriminative validity, and also in regards to making the test a little bit shorter for clients, we have done a briefer version of 7 items compared to the original 14 with a high sensitivity and also specificity as well. So here is the poster. We thought we'd just show you what the poster looked like, and these are the sensory attributes for each of the areas that we will be looking at. So depending on whether or not you're doing the 14 item or the 7 briefer version, all the sensory attributes such as the texture, weight, temperature, and the other ones will be examined. And you will also notice that each object set has a matching pair and also a distractor item. Another thing that the therapist will look at while they're doing the FTOR assessment is how the client actually uses their exploratory procedures to identify what the object is like. So earlier on, Leanne mentioned and asked whether or not you can all feel the texture of the chair or compare it to what the hardness of the chair is. So you'll notice that you're using different exploratory procedures during that process. During the FTOR, the examiner looks at the client's exploratory procedures, and it might even be limiting their ability to identify what the correct objects might be. So now I'll pass back on to Leanne, who will discuss with you a little bit further in regards to assessing somatosensation during function.
Great. Thanks, Yvonne. So as you can imagine, it's really important that we not only assess formally the sensation, but assess its impact in everyday activities the person is engaged with. So one way that you can do that is considering a structured interview called the hand function survey. So this is an interview that asks the person to self-report on their ability to perform these everyday tasks. Now, these tasks are tasks that have been specially selected because over the years we've found that they are tasks that a large proportion of stroke patients who experience sensory loss have difficulty with. Using this survey, we then ask the person to score in terms of their ability to complete that task, whether they're able to do it easily and independently, through to with difficulty or not able to do it at all. And you would also then explore with them in a face-to-face interview some of the nature of the difficulty, the compensation that might be used, and if any level of assistance is required. We also use the Canadian Occupational Performance as a measure to be able to assess the sensation. So when we use this, we ask the client to identify activities that they experience as difficult, that they believe are associated with the sensory loss. And we prompt them to look at this via the self-care, productivity, and leisure domains. And then the person actually rates their performance on that task, as well as their satisfaction using the visual analog scale provided in the measure. Once we've identified 5 particular activities that the person values that are impacted most by the sensory loss, it's really important that we go on and observe them in the context of those functional tasks. So we assess the function, and here's a couple of ideas to think about how you might structure that. So firstly, we observe the client performing the task and identify the sensory demands of the task. So this is really doing not only a task analysis of the particular activity that involved with, but how the performance varies in relation to when there's high or low demands in terms of texture discrimination, limb position sense, and perhaps recognition of objects through touch. We would also observe and record how reduced sensation impacts on the client's performance, and then how the client's performance might improve or deteriorate when we manipulate the sensory demands of the task, so when they're increased or decreased, to help separate out what might be more motor problems or sensory problems, for example. And then we would record some of those observations, focusing not only on the impact on function, but also the performance challenges as they relate to the different texture demands of the task, proprioception, tactile object recognition, while also noting when there's other factors impacting, such as attention, goals of the task, etc. So what I'd like you to think about, I'm going to show you a very small video of a person who has had a stroke, who has experienced sensory loss. And I'd like you to look at some of these prompts whilst you observe this next very small video. And perhaps write down some of your observations. So what you'd want to look at there is the nature of the task, what the task is presenting in terms of challenges, and how the person performs. And in this instance, the person here is able to articulate very well what's going on in the task. So I'll share that with you now, and you can see how much you can observe and learn from the task, perhaps some of those observations being different to what you might have expected. So let's...
Please, perhaps first describe to me a little bit what you notice, and then we can have a look at it.
Yep. I find it difficult to pick up and manipulate to position the fork in my hand.
Okay.
It requires conscious effort not to push it into my hand.
Yeah.
And once it's in there, I'm conscious that it's really very easy not to be gripping the fork as I normally would, just to adapt some other kind of sort of more fisty grab.
Yep. Yeah.
These fingers fatigue really quickly, and once I can't see them, I don't know when they've let go. And so when I'm actually then using the fork, the fingers let go and move off, and I don't know.
Okay, good. So do you want to show me just the normal way that you would do it? Yeah, just... So just even that first part of getting your fingers in place to hold it is difficult.
Yes,
okay.
Yes, and I think I've got a lot more information going on in this part of my hand than this part. And the reason it's this task that's so hard is because it's so heavily reliant on these two fingers.
Because at the starting point as it is now, it is important to see what some of the difficulties that are, as well as what you're currently doing to get over them, but where you want to be at.
Yes.
Good.
So
I think what I'd like to do is get you to cut the whole thing up, because as you said, to keep the position is often difficult.
Yep.
So if you just cut it up as you might normally.
Like at this point, I'm aware that I'm not holding the fork as I'd like to be. I know that I've adopted a completely different hold to how somebody would normally hold a fork. Just to keep it in my hand, it's like, okay, well, I've got enough of a grip that I can exert the pressure to put it in the food, but you know, the whole sort of overhand, shoulder up kind of thing, it's like, well, actually that's not how I want to be holding.
Would you be comfortable to eat out like that, or even at home?
No.
Well, yeah, okay.
I'm conscious of things being tight up through my arm, and through into my shoulder.
So it's working overtime.
And I'm conscious of like really sharp pins and needles feelings through some parts of my fingers.
And can you actually feel the shaft of the fork in your hand towards where your little finger is?
Yes, but when it moves, I'm not always aware of it.
Okay.
But yes, with a hard, sharp, I get muscle feedback.
A little bit more feedback, okay. And when it moves, it doesn't. So is that what you're saying? That sometimes it'll slip around in your hand?
When it moves, the way that I'm aware that it's moved is not because I've felt it moving here. It's because all of this starts going wrong.
Okay then. Great.
And I think that video really highlights some of the key elements of the task that are challenging from a sensory point of view, differently to what they might be from a motor point of view. And you can see at how many levels of that task that may impact. And so then you would use those prompts to help record some of the observations that you've made. And I think it's important for us, again, to think out how can you really observe and focus your observations in a targeted way for the somatosensory impact on performance. And so these might be a way that you can think about it, linking in with what I mentioned before. So, for example, in relation to sensory perception, you may want to particularly note and make observations about the somatosensory performance. So what you might see are things like abnormal pressure exerted on the object, or you might notice that the object's slipping, or they might be using exploratory procedures that are not matched with the sensory demands of the task. And so with, for example, slip, it might be that the person can't actually feel the texture or the micro slips. You would then observe and record in relation to action, so movement components and how well they're coordinated or not, particularly looking at things like object manipulation and whether or not the person's adapting their movements to the sensory demands. You will also notice there that there's a lot of impact in the task context in terms that it might take longer or require additional attention, or that you can see the effort beyond that what's expected for the task. And or you might also observe compensation, for example, using the other hand, reliance on vision and modified or equipment. And I just want to highlight some work of Tamara Wanklin that's in progress, where she's developing up some of these ideas in the context of performance quality rating scale, specifically targeted to people who experience sensory loss after stroke. So we'll finally move into the last part, which is around the application resources, and pass on to that.
Thanks, Leanne. So we've developed the Sense Assess tool, and this is really to provide clinicians with an evidence-based somatosensory assessment tool that can be used in a clinical practice setting to help determine whether or not the stroke clients have any somatosensory loss at different modalities. So as you can see here, as what we've covered with the tactile discrimination test, it really looks at texture discrimination. Risk perception says we're looking at proprioception. The F taught the haptic object recognition. We also know that sensory impairment is also shown to have a negative impact on the hand function and hand use post-stroke. So the test of hand functions such as the Jepson-Taylor hand function test and also the hand function survey has been included as a part of the somatosensory assessment tool. Now, sometimes if we provide this assessment with our stroke survivors, it's a bit hard for them to just really specifically talk about somatosensory loss. Sometimes we do encourage the therapist to sit down with them first and have a bit of a discussion about their how the hand feels post-stroke, whether or not it feels the same or quite different to post-stroke. And so before commencing the sense assess, we have included a sensory questionnaire at the beginning before the tactile discrimination test, which focuses on identifying the patient's awareness of whether or not they've got any sensory changes in the hand or any other parts of their body, and whether or not these changes actually impact on their motor function or daily activities as well. Now, Leanne and I thought that would be a good time to talk about a bit of a reflection in regards to using the sense assess in practice. So we have 4 components here, and the first one is about delivering standardized assessments and also the participant experience. So I've been upskilled by the originator of the test. So Professor Leanne Carey taught me all the skills and tips many years ago now, Leanne, hasn't it been? And really the ability to be upskilled and deliver these somatosensory assessments really highlights the need to focus on these areas. I know when I first graduated from university from over a decade ago, my stroke patients within a rehabilitation ward didn't have that opportunity to really explore a little bit more about somatosensory and about their somatosensory impairment. And that was where I really reached out back to Leanne after my honours with her to focus on this area a little bit more. And when we were able to identify certain areas of impairment and with the assessments, which therefore targets the sense therapy, it really shows that there is that ability to hone in and focus on specific areas of their impairment in terms of somatosensation. Patients also find it a bit challenging to initially talk about somatosensory loss too. And then when we developed that sensory questionnaire and all the sense assess, it really, the ability for them to really have these with to be assessed, they were really thankful the fact that people are starting to really look at these impairments, because sensory impairment is something that you can't see, and if you can't see, this kind of gets ignored, and hence that's why it might be neglected for all these years as well. So having that ability to be training other therapists and using the sense assess in other studies is very thankful and grateful that I'm able to do that. So the next part is about the use of sense assess in the sense implement study. Now, there might be a number of you within the audience today that is involved in the sense implement study. The sense implement study really, we reached out to 8 healthcare organisations within Victoria and also New South Wales to upskill, and I think now we have 150 clinicians, both physiotherapists and also occupational therapists, in the use of sense assessments and also treatment. These 8 sites, so they're broadly, they're able to use this equipment which we have provided, and also give the opportunity for them as clinicians to use these assessments within their local setting, which is really fantastic. Upskilling the therapist, I think there's a few questions coming through already, and I'm seeing those questions, and these are common questions that therapists do ask us, and it is very nice to see that, you know, number one, it empowers them to be able to really be comfortable with assessing for somatosensation with their clients now, and be more confident to know how to treat for somatosensory loss, because it is an area that is quite tricky to do. Some of these commonly asked questions or frequently asked question is, if I've got a patient with high tone or no movement at all, how are we going to actually provide these assessments and also treat these clients? So within obviously this is only a very short, sharp and sweet presentation, but when we do train and upskill our therapists, we really go into a lot of detail in terms of how we actually go about with providing assistance and also how to accurately help guide the patient's hand to accurately assess for certain areas of the test as well. Another frequently asked question that we do get a lot is if the client gets a bit tired and they can't sit and complete the whole sense assess, which has 6 tests, is it actually okay to break it up? And the answer is yes. With the sense assess, there is that option of the full test, which we obviously encourage, but in the event that the client is tired or just can't able to really focus on the actual assessment, there is a ability to make that shorter and break that up into 2 separate therapy sessions as well.
Thanks.
So in the last 12 months or really 2 years, without the with lockdown and everything, we've had a bit of time to really focus on how we can still reach out to clinicians and our patients who has somatosensory loss and continue to provide them with support, because we previously were able to travel around, go interstate and provide them with that face-to-face interaction and training. But really during the last 2 years now, we've really focused as a team to set up this Sense website, and my team and I here today is really happy to showcase this sensetherapy.net.au, which is really a website that allows not only clinicians but their families and the stroke patients and their families as a bit of an online resource. Now, because we're talking a little bit more about sense assessment today, so next slide, Leanne. I am going to do...
It doesn't seem like it wants to. Here you go.
No worries.
There you go, we're good.
Yeah. So as you can see here on the website, we have mapped it out a little bit more so that clinicians and stroke survivors can look at certain areas. So if you're wanting to know a little bit more about sense assess, the assessments in particular, or certain information, it's all online for you, and definitely something that you can use this as more of a resource to reach out to as well. Now, for our clinicians who are here today, we have some current opportunities which we would like to inform you about. There is training coming up here at the Florey Institute at Austin and Heidelberg, and this is a 2-day sense workshop which we deliver face-to-face in person. It usually happens annually, and it's conducted on March the 28th and also the 29th next month. So if you're interested, please feel free to log into the Eventbrite and then register for that. The training, in this training, you'll have the opportunity to not only hear some of these information in more detail, but also have an opportunity to play around with the equipment and learn a little bit more about the sense assess and also the sense therapy as well. Another thing that we're excited to talk about is we will be launching Sense Online. Now, what that means is, as I mentioned before, because we haven't been able to travel and see clinicians face to face, we are now developing an online module and also lessons, particularly on different areas of sense. So not only are we covering everything that we've kind of mentioned today, but also various assessments and also treatment as well. So if you're interested in this, please express your interest and by that email down below here. And finally, we've heard a lot of people mentioning to us recently that their stroke survivors aren't really getting a lot of time with therapy now, and especially in Victoria in Code Brown, like, you know, there is that limited therapy time for stroke survivors, even if they've been upskilled to be trained sense therapists. They just don't have that time to as a priority at the moment. So if you have any stroke survivors with upper limb somatosensory issues, they may be eligible to participate in the sense therapy in one of these following sense therapy centres. So we have them across Victoria, New South Wales, and also South Australia as well. Any details, just go onto the website there.
Great, thanks, Yvonne, really appreciate that. And would like to finish by really acknowledging the whole team. It's, as you can imagine, there's a lot of work that goes into it. We feel it's an important area for people who experience this problem, and there's work in neuroimaging, clinical, and I really want to most importantly recognise and thank all the sites that have been involved and with us along the way to help develop and share some of this information. I also want to just highlight that obviously I'm the originator of this, but there's no financial benefit. What we're trying to do is to get out this information to more people to be able to benefit from the work that's been done by the collective team. And so I'll finish there. Thank you very much for your time and interest, and open up to questions. And I've got both mine and Yvonne's email address there. So thank you, everybody. Thanks, Leanne.
Thanks, Leanne, and thank you, Yvonne. Given that we've had over 200 participants join us today from not only across Australia, I'm not sure if you guys were watching, but we've also had Japan, UK, New Zealand as well. There is a lot of interest in somatosensory impairment following stroke. I found it really interesting to hear that 1 in 2 stroke survivors experience sensory impairment, because we know that sensory impairment is linked to poorer functional outcomes. So thank you both. We've had a lot of questions. We've got a few minutes to answer them, and guys, if we don't manage to get to them today, we will pass them on to both Leanne and Yvonne to answer them offline and get you the answers. The first one we had, Nu was asking regarding the tactile discrimination test. Is this test only for those with intact primary sensation, and do you test the non-affected hand first?
Yes, so Nu, thank you so much for the question. This is something that we commonly get asked as well. We usually, for really some of those research projects, we always assess the non-affected hand first, and then test the affected hand. But in the clinical practice setting, we have listened to the therapist, and they were really trying to reduce the time to try and get it, like, you know, assess as much as possible. So for the sense assess, we kind of just get them to assess the non-affected hand. But we know that tactile, like any of the somatosensory loss, it can occur on the other hand as well. So it can occur on both hands. So if you feel that, you know, there is any sensory impairment in 2 hands, and if you've got the ability to test it, I would definitely recommend that you can test both sides.
Okay, thanks
for that, Yvonne. And I might just add one quick bit. So we test the affected hand. I think you might have said non-affected hand just in passing there, and we're able to benchmark it to normative performance standards in relation to whether or not the person has primary detection, for example, with monofilaments. Sometimes we can find that people have a very severe problem there, but may actually, when they're doing the tactile test, be able to pick something up because it's a more active movement. So I would recommend that people with or without even that first level of detection are able to participate in finding out about their touch sensation using the TDT.
Yeah, absolutely. Still on that subject, Taylor asks, is it inferred that the assessment results from the tactile discrimination test and wrist position test can be generalised for the rest of the limb?
They're specific to the body part. So for example, for the texture, it's for the hand. It gives, and we particularly selected the body part that it's most relevant to. For the wrist, we have done work in assessing for finger position sense test, elbow position sense test, and wrist position sense test. So there is some variation within it, but mostly we find that there's a good linking. So to get to the pragmatics of what might be useful and able to be done in a clinical practice setting, we're focused on the wrist position sense test, but I've still got a bit more of that data to publish on the others to help put it in context.
Oh, fantastic. We're looking forward to that, Leanne. Thank you.
And we often do an extra clinical test, just what you're currently doing to get an idea of those other areas.
Oh, that's okay. So moving on to the functional tactile object recognition test. Yvonne, you might like to take this one. Nu asks, is this test only for those with intact in-hand manipulation skills who are able to explore the object?
Yeah, look, no, this one is a common question as well. Therapists tend to find this quite difficult to understand. Like, if the patient doesn't have active movement, how are you going to actually test object recognition, especially when they've got a hand behind a curtain? And this is where we will train and upskill the therapist in terms of how to actually accurately hold the object or pop the object in the client's hand. We do allow them to try and manipulate the object, but with those who have minimal or no active movement, giving it a go and letting them attempt, and then that's when you would, as a therapist, guide the object in the hand, allowing them to feel the prominent features of the objects without putting too much pressure on their hand. So there's a certain technique in how to do that, and we go through that in our sense workshops as well.
No, fantastic.
I might just quickly add to that too. So each of the test sets in the F-talk are selected to represent certain texture, for example, and so we know what the most optimal exploratory procedure should be for each of the objects that we give. So part of the guided and upskilling is actually teaching the therapist how to provide an adequate stimulus using the most optimal exploratory procedure for that particular test item as well.
Okay, yep. Thank you. You've both actually answered the next two questions from Lauren and Justine. Guys, I hope that answered your questions well. In terms of the wrist position test, Leanne, Sarah asks, is the wrist position test scored based on degrees or off the actual angle, of the degrees of the actual angle, or is it a pass-fail?
No, it's the degrees of the angle. So it's an average error score. And so it's quite sensitive in that regard. And also in recent times, we've got a scale to really help a clinician understand what normal performance through to most severe impairment is. And so we're able to interpret it to a level that you know whether the person's got more mild, moderate or severe, etc.
Right.
As criterion of abnormality.
Yeah.
Thank you. Hayley's asked a question that's very popular. How well do patients with cognitive impairment perform on these tests? Are there certain assessments which work better in that population?
So cognitive, Leanne, did you want to?
No, you can go. That's good.
So cognitive impairment, generally when we do these assessments, we try to screen whether or not the patient have any cognitive impairment. We know that with sense therapy, it is, like as you can see from the video demonstrations, there is a lot of instructions and a lot of steps to follow. And if the patient have highly impaired cognition, they might find these tests quite difficult to follow, and also may not be able to be accurately assessing for their true answers as well. So we usually screen whether or not they've got cognitive impairment, and this is the same for any inattention or neglect as well. So if they've got severe neglect on the affected side, that's something that will compromise the testing results and also the therapy as well.
Yeah.
And just to add to that, we have got some information about how much they can have some level. You really, it's actually put forward to be very much attention focused, and we can help. We've got modifications of the test to simplify the instructions, take people through. So I'm sometimes even quite surprised myself how well people can follow through when they're in the task with the guidance of the therapist.
And Leanne, is the training available for nurses as well, or just allied health staff?
At present, it's been for allied health staff primarily. We have had some nurses who have joined in on the workshops, but for the implementation study and the credentialing, we've focused on upskilling occupational therapists and physiotherapists at this stage.
Wonderful. Okay, I can see Ash is about to wrap us up. Ash, have I got time for one last question?
Oh, squeeze it in, squeeze it in.
Kelly's asked, I just think it's a good one. Do you have a recommendation of when best to commence sense assess in the context of ever reducing length of stay in hospital?
Sector, so they have that there, but we're now colleagues in the acute practice setting to see if we can bring them right back to very to brief and more simplified to take that through. Obviously, knowing and recruiting people, I've seen them, they know about it right from that early point. And so if we can connect with them and help them understand it better from the beginning, yes. But some of these more detailed tests would be too much for them at that early point. But the awareness, and I suppose that's the take-home message for today, please take the time to think about exploring this issue and problem with the clients that you're working with, whatever sector you're in, because it's not only an issue early, it's an issue for rehab and it's an issue ongoing. So I suppose that's the take-home message from my perspective.
Absolutely. No, well answered. Thank you, Leanne. Over to you, Ash.
Thanks, Leah. And I know we do still have questions remaining. So as Leah said, we will pass those questions on to the SENS team and provide you with some written responses to those questions. A big thank you again to Professor Carey and Yvonne. It's been so fantastic to learn from you both today. Please join us for part 2 in this series on Wednesday, the 23rd of February at 2 p.m. Australian Eastern Daylight Time. You can register through the National Webinar Series webpage on Inform Me. You can also register for a CPD certificate and help the National Webinar team improve future webinars by completing our 1-minute survey. It should appear on your browser now, otherwise you can click the link in the chat. Thank you again, Professor Carey and Yvonne, and to all of you for joining us today. We hope to see you at the second session on the 23rd of February. Bye for now.
Thank you, Ashley and everyone. Bye.
Bye.